All right, so one of my favorite topics is everyone bipolar? Because child and adult psychiatrists look at mood swings much different than adults do, and here's why. So, if someone were to ask you a mood swing and automatically diagnose you with bipolar, that's not correct because bipolar disorder has a criteria, and there's certain diagnostic parameters that you must meet. Now, I'll explain the difference between complex PTSD and having borderline traits, which is way more common than bipolar. So in 2026, the misdiagnosis of complex PTSD, meaning over the entire span of your life, and borderline personality disorder as bipolar disorder, which are very different, remains a significant issue in adult psychiatry. And that's why adult psychiatrists don't ever look at childhood, they don't look at trauma. There's a lot of things they kind of overlook, and this is based on not just my opinion, but based on statistics. This frequently occurs to overlap symptoms, institutional barriers, and lack of trauma-informed training, which is absolutely right. So one of my number one criteria is most people have been through trauma. It just depends. So why does this misdiagnosis occur? Symptoms overlap. So if I tell you it, but you don't know, like, okay, what does this mean? So so in hyperarousal CPTSD, there's irritability, racing thoughts, insomnia based on anxiety, can closely mimic hypomania seen in bipolar type 2. Similarly, the rapid emotional shifts in BPD, which is borderline personality disorder, can be mistaken for mood cycles in bipolar disorder. But the shifts in BPD are based on an emotional reaction. So basically, the shifts are much shorter. It'll be like hours, minutes versus days and week, which is bipolar type 1. The Diagnostic Statistical Manual number 5 in the United States, it doesn't not officially recognize CPTSD as a distinct diagnosis because psychiatrists often need the DSM code for insurance reimbursement. They select bipolar as the best fit. That's one factor that should change with the new upcoming DSM, as well as including rejection sensitivity dysphoria, a lack of trauma management. So many psychiatrists focus on symptom management through medications rather than developmental history, which is 100% true, which is why I did the fellowship, to find out, like, what are you like as a kid, because that's how you understand ADHD and many other conditions. So a lack of trauma management. So many psychiatrists focus on symptom management through medications rather than the developmental history, and they're reluctant to talk about trauma because they're fearful of traumatizing the patient. But there's a way to talk to a patient without them diving completely into it. Inappropriate treatment. So people misdiagnosed with bipolar disorder are often described as mood stabilizers or antipsychotics that don't address the underlying trauma. Conversely, antidepressants often used for PTSD can actually worsen the symptoms of bipolar disorder. Stigma and self-blame. The misdiagnosis can leave survivors feeling alienated, as though their condition is inherent rather than responsive to what happened. Worsening outcomes. So it leads to many more hospitalizations based on these mood fluctuations. And with borderline personality disorder, you don't have to be in a hospital. But the rate of admissions to the hospital for mood swings is actually quite rapid. So there are a collection of specialists that are focused on that the CPTSD will be included, and organizations that focus on chronic PTSD or complex PTSD, and there are clinicians who are trained for EMDR or dialectical behavioral therapy. So those are some ways to kind of look at how when someone spends 5 minutes, they don't really get to understand the underlying problem. But Yeah, I hope you learned a little bit.